What's up, Dead Bod Nation? Dead Bod Steve here with another podcast, and I've got one different for you this time. We've always talked about other people's recoveries and how they've triumphed over their hard times in life, but I have someone who's in the pharmaceutical industry today. I have someone who I have known for a very long time. I've actually been with him in his journey with the pharmaceutical industry. I have Dr. Jaron Stout. Jaron, thanks so much for coming, man.
Yeah, of course. Yeah, it's funny. We have known each other a long time, and it's funny. I was thinking like a couple of months ago about because you brought up coming on the show, and I was thinking when we were younger, when we first met, and we were neighbors for a while there, we would meet up and we would talk all the time about sports and steaks and music and great movies and TV shows. And now we talk about politics and family life and all the boring stuff that, like we never thought we'd be talking about and
We're old
careers.
men.
And
We are
just,
old men now.
yeah, all you youngsters out there, just know it comes around. Like you'll eventually start talking about this boring stuff that you hate. So it comes around eventually.
It
And yeah,
definitely
thanks for
does.
bringing me on today.
For sure, man. We've been talking about this for a while, so I'm really glad we can make this happen now. Go ahead and introduce yourself, where you're from, and your expertise in the pharmaceutical industry.
Yeah, so I am Jaron Stout. I'm owner and CEO of Collaborative Pharmacy Consulting. I have been a consultant pharmacist in nursing facilities for 13 years now. A consultant pharmacist is a required position in nursing facilities. So CMS, the governing body of healthcare, regulates that every skilled nursing facility is required to employ a consultant pharmacist to review everyone's medications every month. I help meet that need, and I do it without any association to any dispensing pharmacy. And I want to make that the norm. I'm trying to overhaul the industry, and I'm putting a lot of great things together. I've won a national award for my efforts because I have a very progressive practice that is very centered on collaboration with physicians and the nursing homes themselves, providing patient education, enhancing the sub-level of services that we offer to these nursing facilities, because this is where we desperately need more oversight on the appropriate use of medications.
Absolutely. And so, for those who don't know, Jaron is a pharmacist who tries to get people off of some pharmaceuticals, and not completely, but he likes to balance it out because we've had so many conversations about this. We go golfing at least once a year together, and we talk about how there's so many overprescribed drugs, and the United States is just overdoing it. And that leads us into our first topic. So, why do you think there is such a rise in prescription drug use in America?
Well, first of all, I want to emphasize that there's two sides to this argument. Right now, I feel that we overprescribe, but that doesn't mean that all drugs are bad. So, as a pharmacist, I have this is a perspective I apply to my philosophy of life in general, and that is that the difference between a therapeutic drug and a poison is literally the dose. So you can take anything, any philosophy, any ideology, any substance at a high toxic dose, and that is what makes it poisonous. And so, even though we are overprescribing drugs right now, that doesn't mean that all drugs are bad. There are many drugs that have a great purpose, that are providing value and improving our lives. So, I want to make that very clear. However, right now, there's data, and this is data that basically is what helped me. It helped me create the genesis of the company that I run today, and that is that 66% of medication-related adverse events are preventable, and that's nursing home data in an industry where consultant pharmacists have been a required service for over 30 years. Which, once again, that proved to me that what consultant pharmacists currently do and the current standards of practice are completely insufficient for the needs of the population. And so, rather than pointing to potential problems and then telling nursing staff to address it, I actually assess the problems and help implement effective and useful clinical solutions to the problems that I identify. And I collaborate with the medical director and the facility management to make sure that these are things that are implementable and that we can address with a measurable change. Another thing that I think there's a massive contributor to the overuse of drugs in America right now is that just to get a drug on the market, requires a massive investment. So what happens after you make that massive investment? Well, now you got to sell it. So you're going to pour even more massive amounts of dollars into salesmen and marketing, and they are going to go out there and push that drug to these practitioners out there, and they will find ways of getting their drug to the American consumer with any symptomology that needs to be addressed that they think their drug can help treat. And so there's a massive amount of marketing that goes into this. And keep in mind that when you do this marketing, what that means is you're going to manipulate data. And there's a lot of examples I could talk about this for days. The most obvious one is a fairly recent one. And this is a common tactic that drug manufacturers use, that drug reps use, and that is they will take the data and kind of flip it around and make it look better than it really is. So just as an example, statin drugs are used to lower cholesterol. And I might add that we had medications before statins came around. We had medications that would reduce cholesterol before they came around. Okay. There was no benefit to reducing cholesterol until statins came along. So obviously, and we can get into this if you want to, but obviously statins provide more benefits than just reducing cholesterol. However, what they did was they took this data and they said, okay, 98% of the people who were on a statin did not have a heart attack. 98.1%. However, the people who were not on a statin, 97% of them did not have a heart attack. So that is a difference of 1.1%. That is the risk reduction. That is the direct risk reduction. What they do is they flip it around and they say, so that's a 1.1% reduction. We're going to divide that by the 3% of people who experienced a heart attack because they weren't on a statin. And that, when you divide it out, is 36%. So what they do is instead of giving you the direct data, they give you what's called the relative data. The relative risk reduction is 36%. And just to kind of coincide with what I said earlier, there's always two sides of the story. What bugs me is that the people who are anti-statin use this same tactic. They'll release a study that says statins increase your risk of diabetes by 23%. But once again, they used relative risk to do that. When you look at the hard data, it was a 1% increase that they flipped around and used relative risk to say that it's a 23% increased risk. So once again, there's a benefit to statins. Obviously, it's inflated. It's not as great as they claim it is. And it's used way more statins are used way more broadly than they should be, especially in nursing homes where I work, where healthcare practitioners have just been conditioned to look at your lipid panel and say LDL cholesterol, LDL, when we have more and more data that says that's not the core component we should be worried about. Now, I'm kind of going on a rant here, but another aspect that is massively important to the overuse of drugs, and that is because we have a very poor American diet. It's interesting.
I agree with that one, 100%.
Yeah, I mean, in the 80s, our country set a goal to reduce fat consumption down to 30%. We accomplished that several decades ago, and obesity is still rising. So fat is not the problem. There's several problems with the American diet. The biggest problem is just processed foods. Processed foods have a lot of diet health problems that they are associated with. They also give you a lot of heartburn. So what do? We don't want to deal with the heartburn, so let's take a pill for that. The most commonly prescribed pills, the most vastly overused medication in all of healthcare, are called proton pump inhibitors. They have a side effect profile. Now, they have a side effect profile that is not immediate. In fact, it almost seems as if there's no side effects. But when you change the pH in someone's stomach, your ability to absorb minerals and nutrients is impaired. So your bone density goes down, your risk of fractures goes up. It also increases risk of pneumonia if you use it inappropriately for extended periods by 27%, which is pretty significant. Now, that being said, that's for the older population where I work in nursing homes, ages 50 or 60 and up. And so what happens is, I actually heard a gastroenterologist tell me this once. This was really interesting, but proton pump inhibitors generate their own need. So Now, when you take a PPI and you take it for several months and you think, oh, maybe I don't need this anymore, and you try to stop it, they have now built a balance in your stomach to where when you stop it, you're going to get rebound reflux and it's going to be miserable. And if you don't just power through that misery for a week or two, you're just going to restart the drug. And every time you stop it, this happens. You now psychologically think, well, I just have to take this the rest of my life. And now you're creating more potential hospitalizations down the road with fractures and pneumonia hospitalizations and Clostridium difficile infections. The risk of other hospitalizations because you just can't stop taking this drug because you get rebound reflux. And that's a key component here. If we aren't educating people on this impact of rebound reflux, they're just going to keep taking it. And they just think, oh, I have to take this the rest of my life. And another thing is our diet contributes to hypertension. You know, high salt diets, all that fun stuff. Our diet contributes to obesity, and our diet contributes to diabetes, which is a massive problem in this country because we can't seem to scale down our carbs because carbs create, once again, a craving for more carbs. And it's a cycle that is vicious. And we just refuse to regulate food companies and take all these additives and sugars out of all the food that doesn't need all those additives and sugars. So that's my opinion on how we got to where we are with the overuse of medications currently.
So one of the things I want to go back to, and have you kind of expound on this. One is we have all these new conditions than we ever thought of that they created a drug for. Now they want to push it, right? How many of those do you see that are just absolutely ridiculous? So one of them, when I saw it was, hey, if you feel tingling in your arms multiple times a day, you need this drug. And it shows people, right? They're all happy, just like you said, it's with the marketing scheme. Happy, they're doing great, and then it lists all the side effects. And I'm like, I'd rather have my arms tingle than have all these other side effects. And so how often do you see people saying, I need this? So I think the marketing goes into a consumer demand, right? I don't want to wait. I want it now. I need this. This is what I want. I'm going to go to my doctor and just go get it. How do you see that as affecting the rise of taking medications today?
You know, I think one of the components here, and this is a fascinating topic for me. I love diving into sociology and generational gaps, especially since I work in nursing homes. There is a massive generation gap as far as drug use goes, and not recreational drug use. We're talking about therapeutic drug use here. Um, I have a very difficult time convincing people in the boomer population that they don't need a drug because that's the way they were raised. Um, you're sick, we're going to give you a drug. You have a problem, we're going to give you a drug. And this is a cyclical thing that happens in every society. Right now, our society has cycled around to where, okay, let's kind of try to scale down drugs because we've overdone it here. But boomers are still in the frame of mind that they were raised in. They are still in the frame of mind that, oh, I have a problem, I need more drugs. And no matter what I tell people in this system, sometimes in the nursing homes, hey, this drug you're on, Mucinex, over the counter, guess what? Data shows there's no benefit. In fact, the only people who get a benefit out of Mucinex to loosen the mucus in their chest, the only people who get a benefit are the people who drink lots of water. So what do you think loosens the mucus in your chest? Is it this dried up tablet you just consumed, or is it all the water that's you just put into your blood system that's loosening the mucus? And also, if you use humidifiers, that's more effective. But no matter what data I give them, they're trained that, and the placebo effect is so real. There's studies that show even when you know it's a placebo, you still can get a benefit out of it. So I can't convince people if there is a perceived benefit, there's nothing I can do to turn that around. It sometimes has to come down to something detrimental happening, unfortunately. But that's a whole new discussion. Where do we regulate that? You can't force somebody with emphysema to quit smoking. So you can't force somebody to stop taking a drug where there's a perceived benefit either. But we can do education and we can do those things and hopefully make an impact and move that needle a little bit. But once again, one of the key components that I like to emphasize, I love that you brought up tingling, because there are drugs that can cause neuropathy. There are diseases that can cause neuropathy. So rather than taking another drug, why don't we identify the root cause? Because that tingling in your finger it's an indicator that you're developing diabetes, because neuropathy is a very core component of having diabetes. So fix your diet, B, what drugs are you taking? Because some drugs can cause that. Do you really need to take that drug? Let's assess the risks and benefits. And our healthcare system is designed to start drugs, start drugs, start drugs. It's not, and this is a huge component of what I do. It's not designed to identify when the duration of that drug has been met and there's no longer benefit from it. So constantly evaluating the risk versus the benefit of every drug on every person is a valuable component, and that's where pharmacists can make a huge impact in our healthcare system.
So you said before you collaborate with physicians a lot, right? That's part of your job.
Yeah,
How often do you think a physician, or how, I'm sure you guys have your little round tables where you guys talk about experiences. How often do physicians say, didn't want to give someone this, try to do this, try to go the ethical way? Because I know a lot of doctors, if I have even high level cholesterol or anything that's just barely above normal, they say, hey, change your diet, change your, water consumption, exercise more. I get that a lot from doctors. I don't get a, hey, here's a pill, right? How often do you think it's more of the consumer, like you were saying, the boomers, than it is the doctors? Because I know doctors are the ones handing them out. However, how much do you think there's a social pressure from their customers to get what they want and not what the doctor actually wants to do?
that's a great question, and I think there's two aspects to this. Absolutely, it is consumer driven, especially in the older population where they have been taught that whenever I have an issue, I go to the doctor and I get a new drug. Um, so a couple things here. A, they're constantly requesting it. B, the practitioner, our healthcare system is massively overburdened. So it's hard for them to dedicate time to educating them on the dietary problems that are contributing to their symptom. It's hard for them to dedicate time to convince them and educate them that they don't need a drug. They are still thinking about the next 5 to 12 visits that they have ahead of them, that they have to finish in a timely fashion and document everything they did to justify what they're doing. Um, so a huge aspect of that is them just taking the path of least resistance. I still have to. I can't keep educating this person. I have to move on. Okay, I'm going to hand out this drug. Where where my services are required is in skilled nursing facilities. However, I still do some work in assisted living facilities where my services are not a regulatory requirement, but some facilities ask me for my input. But since they're not regulated, I get very little success. In fact, no matter how important the issue is, I very rarely get the prescriber in house or whatever to actually respond or implement it. And their rationale is I'm never going to convince them to stop taking their Mucinex. I'm never going to convince them to stop taking their probiotic. Um, those are very simple scenarios, but yes, like a lot of it is absolutely driven that they're just not going to accept anything other than continuing to take their drug, no matter how much data we show that, no matter how much data we have that shows that we're overprescribing and it's creating more hospitalizations and more mortality. I hope that answers your question.
Oh yeah, definitely. And you've got to think now with all these prescriptions that are being written, with everything that is going on with the pharmaceutical industry, there's got to be hidden costs that are happening with over medication or with people taking too many drugs. What are some of the things that you've seen, consulting with these firms and also with these um, assisted living facilities and the nursing homes that you work with? How are you seeing these things being affected with these extra costs? And I'm not talking just financial costs. There's got to be costs with health. There's got to be costs with other side effects and other things like that.
Yeah. So, using so once again, one of the core problems, like I said earlier, is we have a great system in place to start drugs to treat a problem. We don't have great stop points in place. And one of the biggest issues in healthcare, and it's a buzzword, is transitions of care. So, and I'm right in the front lines of transitional care. Um, so somebody has a heart attack, they go to the hospital. Um, they have a stent placed in their heart, they have a heart surgery, and then they're placed on two drugs simultaneously. Both of them are called antiplatelets, aspirin and Plavix. You're supposed to be on this combination after having that stent placement for 6 to 12 months. If you had a stroke, it would be similar. You'd be put on two antiplatelet agents, aspirin and Plavix. There are some other alternatives, but that's the most common. And if you had a stroke, the duration you're on both of them is 21 days, sometimes up to 90, but most generally it's 21 days. So after that 6 to 12 months has been met for a stent or the 21 days is met for a stroke, then you're supposed to narrow it down to just one agent. Usually it's just aspirin, you get rid of the Plavix. What happens in these transitions of care, they go to the hospital and then they're sent to the nursing facility. Uh, and in this nursing facility, they receive all the medication orders from the hospital. It comes in, they administer them, and then they discharge them home. The problem is the hospital, and this is a problem with transitional care, they will document in the progress notes or the history and physical, I want aspirin Plavix together for 21 days, then aspirin alone. And then they will fail to put that in their discharge orders. So that stop date is not added to the nursing home. And then when they go home, they weren't educated that there's supposed to be a stop date and they'll just continue both. And that has become my most common intervention in short-term stays post-acute after recent hospitalization is appropriate duration of that combination. So to answer your question as far as cost goes, when we don't have these stop points in place to identify appropriate duration of use, data shows that keeping this combination in place beyond that duration, there's no additional benefit, but incurs additional risk. So once again, 66% of medication-related adverse events are preventable because we have a tendency to start meds and leave them there way beyond the duration that they're intended or should be. So the cost is we're incurring more health problems by doing this, more hospitalizations, and hospitalizations average cost, last I checked, was $90,000, and I think that was during COVID. I'd be surprised if it hasn't gone up since then. So the cost is we are generating more healthcare dollar, costing more healthcare dollars. Another component here is just an example, COPD, chronic obstructive pulmonary disorder or disease, is a progressive condition, usually from people who spent many years smoking. There's a triple cocktail of inhalers that will help minimize your symptoms and reduce your risk of hospitalization. However, one of those actual ingredients is an inhaled corticosteroid. Steroids reduce your immune system. So in people with COPD, if we give them too many steroids for too long, we increase the risk of developing pneumonia, and that's even worse when you have COPD and you're going to go to the hospital for it. So a great way of describing the cost is what's called the prescribing cascade. And that is when you start a drug, the physician says, okay, I want to see you back in 4 to 6 weeks. You come back in 4 to 6 weeks. You were started on, let's say you were started on lisinopril, which is for blood pressure. However, it's known that ACE inhibitors such as lisinopril can cause a chronic dry cough. So you follow up in 4 to 6 weeks. You're coughing. Oh, you're not feeling well. Let's give you a cough suppressant. Oh, that's not working. Okay, let's give you a higher strength one. Let's give you benzonatate. Now you come back in a week or two. I'm still coughing. The benzonate's helped, but now I'm really dizzy because benzonatate causes dizziness. So then you give more drugs to treat the dizziness, and then they cause dry mouth, dry eye, and constipation. And so the prescribing cascade is we're no longer treating conditions. We're treating side effects of other drugs with more drugs. And so the more we add on, the more difficult it becomes for the patient to remain compliant because there's so many to keep track of. Then they'll miss one, and then they'll miss an important one, and then they'll go to the hospital for it. So it is a problem that compounds very quickly, especially in our elderly, our most susceptible population, ages 65, 70 and up. So,
I see that too with kids when they're diagnosed with ADHD, when they're diagnosed with autism, when they're diagnosed with anxiety, and those have side effects, right? A lot of them are gaining weight or not being hungry
yeah,
and not being able to sleep. And so then what happens is they say, oh yeah, let's give you another one. Let's give you another one. And they do that. They just continue to try to counteract those side effects. So I think it's a common thing, right? No matter what you're doing. And even
absolutely.
for me, ever since COVID, and I don't know why this is, I don't know if it's because of COVID, ever since I had COVID multiple times, right? Being in education, I get chronic coughs every time I get sick. Every time I get sick, I get a chronic cough, never without fail. And what they were doing is they're saying, well, your cough is causing inflammation in your lungs, and the inflammation is causing the cough in your lungs. Let's give you this. Let's give you this. First few times it actually worked. Next few times it didn't work. Right. So I had to
Yeah,
find other alternative solutions to that. But it was always, let's do this, let's do this, let's do this. And then it was those side effects. Like you were saying, it's those side effects that just come out and you either deal with it and wait for your body to really adjust to the medication, or get off the medication, right? Because like you said, there's got to be another root cause of what's going on. And a lot of
Exactly.
times that can be something natural. Like you said, diet could be a big one on that.
Yeah.
And so why with okay, so we have all these drugs out there. We have so many. They're regulated like crazy, right? Food is regulated like crazy. I don't think they do a good job regulating these things. I think they have a little paper pencil checklist that they go through, and if you don't follow the checklist, it won't work. But why is it so easy to get a prescription nowadays?
Um, that's a good question. I think they're, once again, when you have an overburdened healthcare, they're taking the path of least resistance. They're just going to hand out the drug because that's easier than educating or finding non-farm measures, and also the patient feels gypped. Also, there's too many silos in our healthcare system. You go to the doctor, you don't agree with them, so you just go to a different doctor, and you go to a different one until you get what you want.
Yeah,
There's no way.
we call it shopping, right? That's called
Yeah,
shopping.
doctor
So the
shopping.
kids that are at school do it all the time. If they go to a staff member and the staff says no, they go to another one to see if they say
Yeah,
yes. It's so common. But yeah, so okay, so I can see that. So adults, did you see that? So you did do work in pharmacies before you
yeah.
started your
I've
company.
worked in retail as well, not in a few years, but yeah.
Yeah, did you
And
see this a
they'll,
lot where
oh yeah, yeah, they'll pharmacy shop as well. Part of it is, oh well, they don't have it in stock, but part of it is also, oh well, this pharmacist won't dispense it because he has an ethical disagreement. Well, I'll just find a pharmacist who won't disagree ethically to allow me to take my opioid with my muscle relaxant and my benzodiazepine. Um, so there's a lot of that, and there's there's a lot of problems in our healthcare, but I think overburdening, over marketing, um, over overdoing the whole aspect of you have a problem, start a drug. There's never any assessment, and this is what I'm trying to change in my practice. Okay, what drugs are you on right now? First of all, what's your symptom? Okay, let me look at what you're on already and identify if any of them are contributing. Okay, this drug and this drug combined are contributing, but if I tweak it so you're taking them separately in separate times in the day, or if I change it so that you're we change one of those drugs to a similar one that's doing the same thing, then that interaction is no longer there. So a lot of it is consumer driven, and a lot of it is just the healthcare side is just too overburdened and fragmented to figure out that there's a problem with some of these patients pulling these types of games. And then once again, that's a whole new ethical discussion. Do we centralize data? Do we make it so that, and then we're overregulating, So once again, the difference between a drug and a poison is the dose. We can put safeguards in place, but if we overdo it, now it becomes authoritarianism, So
and doctors can only do what the clients tell them, right? They can,
right,
if a
yeah,
patient comes in and says, here's how I feel, doctor can't sit there and say, nah, you're a liar, no, you're not exhibiting that. They just go in and say, okay, here's what I can do for you, right? And they give them those options. They can't sit there and diagnose someone fully without their descriptions and their feelings. Blood tests only do so much, right? And
right,
checking their heart rate only does so much. They have to rely on what they say. So I can definitely see that someone going in, and if they Google the symptoms now, right, they can just go in and say, hey, here's my symptoms. And doctors
yeah,
might say, sounds a little perfect, but if that's what you're saying, I can't say you're lying. Like, doctors
right,
would get sued left and right, right? And so that, yeah, it's crazy. I mean, we have to come together as a society in a lot of ways and say, hey, enough is enough. We need to kind of figure some other things out and help it. And I think, like you were saying, it goes in cycles. I think our generation and the younger generation have been kind of seeing this and saying,
yes,
hey, there's something going on. There's a little too much. It's become a huge controversial topic on social media, right?
it has.
And so let's go back into what you're doing. You kind of touched it, but you started a consulting business and you've been growing ever since, right? How long have you been in business now? When did you start?
Yeah, I officially created it in 2017. I've been doing it full time since 2018. So it's been about
Okay, so it's
eight
been almost
years.
10 years.
Yeah, yeah, it's coming up
So
on it.
so you've been doing that. What, as you've been going through, and you're primarily in the state of Utah, right?
Yeah,
What
4 states.
have you seen as a benefit? Yeah. What, you're in 4 states now?
Yeah, not
Oh, I
much.
had
I
no
mean, I
idea.
have one home in Las Vegas. I have two facilities in Tucson, and a couple in Wyoming. I'm about to get one in Idaho. But so it's small footprint in other states, but that's also going to change soon. So I
See,
didn't mean,
we need to go golf more. That's
yeah, we
we have
do.
to go
We
golf
do.
more. We don't talk about it enough. But you're definitely expanding, and you've seen some growth, some reduction, and then and growth again, but mainly growth. So as you've gone through and done this, what are some of the benefits that you've been seeing, and how is it helping people specifically? Right, like how is it helping them with their quality of life? Is what people will want to know.
Yeah, I will say that um, what I'm doing has been providing a benefit, and that's why I've grown every. There's only 1 year I did not grow, and that was 2020, COVID, when I wasn't even able to step foot in nursing homes, and I think my revenue shrunk about $4,000. So I mean, it wasn't a significant hit, but every year since then I've been growing exponentially. I now have 20 employees, and it continues to grow. I think, and I'll give you some of the genesis here. Early in my career, I was. This just goes to show how long overdue my industry was for an overhaul. Um, and I talked about aspirin and Plavix earlier. I was taught to go into a nursing home as a consultant and say, "Oh, they're on aspirin and Plavix." I should tell the nursing staff that this person is at a higher risk of bleeding, and that's what I'm going to do. And that's a huge benefit I'm giving this nursing home. Well, guess what? A nurse, part of their baseline training is to monitor for bleeding. It doesn't matter if there's a risk there or not. Me telling them to monitor for bleeding is like uh, a nurse walking into a pharmacy and telling a pharmacist, "Hey, you know what? That's an extended release formulation. You shouldn't cut that in half." Uh, Thanks, nurse. So, me doing that was providing no value, no benefit. Um, and that's where I started to, and I remember I showed up to one of my nursing homes while I was still employed by a pharmacy, and they looked disappointed, even though I had great rapport and I was friends with them. And they said, "Jaron, we love you, but you're just going to give us a gigantic stack of paperwork that we're going to have to sift through that isn't really beneficial." And that is the day my career changed. I started to think more about, okay, well, you're right. I'm actually not using my expertise. I am just pointing to potential problems and regurgitating data from drugs.com. I'm not actually assessing this data and identifying good solutions to these problems. I'm just saying, "Oh, this might be a problem. You might want to look into that," and then walking out. So that's what changed my career. Um, and I collaborate with medical directors. I help them implement. I have discussions with them on my findings, and across the board, like I can't emphasize this enough. This is not me being grandiose. There is literally nobody in the country who does what I do, and that's why I've won a national award. That's why I'm growing like crazy, and that's why I'm ruffling some feathers, maybe. Um, I might have offended some people just because I'm growing and I'm replacing them on a large scale, and it's I've got deals in the works that are only gonna get bigger and ruffle more feathers. But this is what needs to happen for good change to happen. So just to give you some context of some of the stuff I've been able to do. Um, I remember early when I started my own company and I started to collaborate with a medical group. A good friend of mine, Cameron Peterson, started to invite me into some of his nursing homes. He's a physiatrist, which is physical medicine. Um, they treat pain and help him improve and treat rehab, all that fun stuff. Great physician, great friend. He brought me to these homes to help him with transitions of care because he worked in a rehab hospital. He would send people to skilled nursing, and they would have tons of med problems that I would help him address. One of them, I mean, I fixed tons of stuff, but one time I walked in and met this woman, and I said, "Hey, I noticed you're on Prozac." And it was a tiny dose, like 10 milligrams daily. And I was like, "So how long have you had depression?" And she looked at me and she said, "I'm not depressed. I've never had depression." I was like, "Oh, why are you taking this?" And she's like, "Oh, my husband died 35 years ago. So the physician told me this would help me get over it." And she just, and so, this is something I wanted to bring up earlier as well, because that's one of the reasons meds are over. Like, it's so easy to get meds. They'll just renew it. And this is what happened for 35 years. He just kept
Mhm.
renewing the Prozac until I finally told her, "You don't need this. Don't take meds that you don't need." Right. And so that is one aspect that I think is vastly overlooked. And also, in fact, I was also saying earlier how I have some other deals still being negotiated. One of the biggest aspects of growth that I'm experiencing right now is addressing psychiatric care in nursing facilities. And that's because I want to team up with psych providers and start collaborating with them to where, rather than starting a new drug because you are anxious or because you're psychotic or because you're confused, rather than adding a new med right now, how about I have my pharmacist review their meds, identify what is contributing to their behaviors so that we can identify and address that before we add more meds. So a great example of this is if somebody has, if they're in the intensive care unit and they become what's called delirious, they will give them an antipsychotic called Seroquel. That's the most common one. Well, good news, we're treating their psychosis associated with their delirium, but Seroquel is highly anticholinergic, which can cause delirium or excessive confusion. So we're treating any psychotic episodes, but we're also prolonging that delirious episode of confusion. So that once again, if they're confused, we're gonna, rather than adding an antipsychotic, let's get rid of the other anticholinergic meds that are on board that are contributing to their dreadful confusion right now. And last of all, my biggest success story, it came pretty early in the after the creation of my company. Once again, with my friend Cameron Peterson, MD, I once again in a transition of care. There was a patient who had Parkinson's disease, and she was hospitalized with seizures, new onset. And so in the hospital, her seizures were just continuous. They couldn't get them to stop. They just kept occurring. And then she also became confused and psychotic. And the doctors told her family, "We're sorry. She's never coming back. This is it. Like, she's gone now. You're not going to see her ever again, her normal self." In the nursing home, she was there. I was looking at her meds. While I was looking at her meds, she had more seizures and they sent her back to the hospital. While she was there, they added more drugs to prevent more seizures. Wise choice. I identified that she was on a muscle relaxer called Flexeril, in addition to tramadol, and in addition to an antidepressant. The three of them combined was significantly increasing her risk of seizures. By fixing and getting rid of the tramadol, replacing it to something else, reducing that, or maybe kind of getting rid of the Flexeril to see if we could go without it, that alone made a huge impact. Her seizures stopped and she returned to normal. So it just goes to show, like, even though these drugs are beneficial, even though they're powerful and useful at giving us good health and prolonged lives, there's a balance to it. And if we're not careful with the appropriate oversight, we can overdo these medications and create more problems with more cost to our healthcare system. And once again, more burden to our overworked and overburdened healthcare staff.
No, those are good stories, man. And being able to see people improve is probably one of the biggest,
Yeah.
things in your work that you can actually say, hey, yeah, this is what we're trying to do. We're trying to help improve lives, trying to help improve the quality of life so that people aren't so stuck on these medications and dealing with all these side effects.
Yeah. And once again, it was collaborative because the family I spoke to, they were reluctant, like, "Are you sure? This sounds fishy." And then I called their neurologist, had a discussion with them, and they're like, "Oh yeah, I like this. Let's give this a shot." And across the board, they were all like, "Wow, this was great. This was a great intervention. It fixed the problem." So the more we collaborate, the more we educate, the more impact we can have in healthcare. So
yeah, for sure. Especially when you have so many people involved anyway. You have so many hands going into this whole process anyway. If everyone's on a different page, yeah, a lot of confusion if everyone's on a different page, right? So you being able to come out and say, hey, let's talk about this and let's kind of get on the same page. I'm sure you see a lot of benefits with that. Absolutely. For sure.
Yeah.
So awesome, man. Thank you so much for joining us today. If you guys have any questions, throw a comment in the podcast and we'll see if Jaron has time to get to it. Probably not. He's a busy man. He can't even go golf with me most of the time. Thank you guys. Yeah, for sure. Thank you guys so much for tuning in. Thank you, Jaron, for coming in again. Appreciate you, man. And we'll see you guys next time.